And we're back with On the Record with Tiffany and my special guest, Dr. Richard Gibney. Dr. Gibney has been a pioneer in patient empowerment. And since this pandemic has been going on, Dr. Gibney has used his powers for good to talk to others about patient empowerment and incorporating patients into the process. And our government noticed Dr. Gibney's work and acknowledged it. Why don't you, because I know you're not going to say anything about it, Dr. Gibney, so let me go ahead and give you that attaboy that you so deserve for your good work. Tell my audience about what you've done to contribute to the patient empowerment movement.
So with this awakening, and you're right, my story is that back in 2006, I went to my first IHI meeting that said, you can do better.
Mm-hmm.
And we thought, wow, okay. So we taught us the whole idea of how to do quality improvement. Then in 2012, a group from Jönköping, Sweden came and showed us how self-care, because I'm a kidney doctor, nephrologist, we're doing all this stuff kind of in an assembly line way. The patients come in, they have the treatment, they leave, but we don't allow them to be involved in the care in a significant way. So they say, what if you did self-care? Self-care in the sense that if I said to you, would you like control of your medical problems or whatever they are? Would you like dignity and hope, optimism and joy going forward? And our experience, of course, was that 99% of people said, well, yeah, heck yeah. So what we then developed was we changed, and then you have to be willing to shift your process and you shift your protocols. And because when you shift them, then you say, you know what? For example, we said, okay, how about if we coach and train you how to build your own machines? So instead of us doing it for you, you take the disposables that go with the dialysis machine, put in the lines, the dialyzer, the heparin dose, etc., do vital signs, etc., all that kind of stuff. And so we had to kind of think about all the barriers of why we could not do this. And of course, all the barriers that we made up all just kind of vanished and went away, because we were then going to say, we're going to empower, not self-care, meaning we're giving you something. We're giving you power and authority to make things happen, but we're going to be your coach, your trainer, your mentor, your educator, meaning we're going to be your support system while you do these great things. And so all this sounds very nice, and the patients were joyful and happy, and they were having a good time. They were coming up with good suggestions on how to do things better, because you can't just have one system for everybody. Everybody has different needs. And so, but that doesn't, you have to, if you do that, you've got to keep data. Because if you don't have data, then I'll say, well, you know, that's all real nice and sweet, but do you have any evidence this actually is of any value? So we kept data. And the two key parts, our quality numbers were always very good, but the data that you want to look at, there are three things you want to look at. The triple aim from IHI started 10 years ago was, number one, decrease the mortality and hospitalization rate. Number two, decrease costs. And number three, improve the patient experience. So what we did and showed that over a 4-year period from 2015 through 2018, 4 years, we dropped the mortality rate in half, dropped the hospitalization rate in half. So obviously you save a ton of money, and you also dramatically improve the patient experience because they're not sick, they're healthy and they're happy and they're doing well. So this was really extraordinary. We thought most people, if you get a little tiny incremental improvement, you go, wow, it's 0.1 or 0.2% better. This is 1/2. And you say, well, probably you were cherry picking, like just doing a few really perfect people. No, we did everybody, which proves that all people are good given a chance and an opportunity. And so we were up to almost 500 patients in our clinic that were doing their own care, and they demonstrated the joy, the caring, the love, the sense of service where they would help the other patients, where they would help the other staff, where it was this whole concept of partnership and collaboration. And that's probably the next place we go. So if you'll empower your staff, if you'll empower your patients, then the next issue we have to talk about is collaboration. How do you get them to collaborate? How do you get everybody to work together as a team if you're doing all these magical things?
When you go over to a new, I want to back up to when you go to a new hospital or a new dialysis unit and you're introducing this to somebody outside of your system, because now you've done your 800 patients and gotten them into this system and empowered and moving. But how do you go to a brand new place and introduce a concept that is not a part of the thinking within their system?
Well, and again, we're early on in this whole story, but it's exciting because the first step is you have to first listen. And you go in and you say, tell me what are your, for example, we're working with DCI, a company based in Nashville, Tennessee. We're working with the University of Texas Health Science Center, San Antonio, Dr. Sharma, the chief of renal, and their dialysis, transplant, home therapy, CKD program. And I've just begun that journey. So the first step is you say, tell us, what are your frustrations? What are your pain points? What are your pressure points? What frustrates you and makes you grumpy? And you say, gee, you know, we're not doing as good a job, or, you know, things aren't going as well as we'd like. But you tell us first what that is. And once you've gotten that sense, then our job is to then say, okay, based on that, here are the shifts that we would like to suggest you make in your processes and protocols. Because if you won't shift, you know, we've proven over 50 years that if you keep doing the same thing, you know, every process is perfectly designed to get exactly what you get. So if you do it in a certain way where the results are not very good, they will be bad like that for 50 years. Mm-hmm. So we say, okay, now are you willing to change to get dramatically better results? And that whole issue of the triple aim. So the first thing we have to work with is processes and protocols. But in doing that, you're going to get tiny little victories. For example, you see the patients, like you set up this program of teaching and coaching and training for the patients. And you see the tiny victories of the joy and the confidence when they can do things themselves and they understand how things work. You see the joy of patients that, if we used to, this is like a bad, really bad word called non-compliant patients. We have none, zero. Now, before we started doing this, we had tons of them because we had a bad, the doctors and the nurses, etc. They were all great. The patients were great, except we had the wrong process. So if you'll switch it to meet their needs. So for example, putting a rancher who's hardworking at his ranch with cattle and running a combine and raising cotton and wheat, etc. He can't come to dialysis 3 times a week. A Hispanic gentleman who's got a taco stand, and that's how he makes his living. But he doesn't get his work done until 5 o'clock in the afternoon. Well, you say, well, you got to quit your job and quit your business so you can come here to learn how to do home therapy. No, thank you. That'll kill him. So what you do instead is you say, well, wait a minute, we'll change our system. So we'll set it up so we can do you in the evening or weekends when it works for your schedule. So this is the whole idea. The same thing with people that have, again, we didn't cherry pick. Now we started off with the easiest and then moved on to more, but we took the patients that were frustrated and angry and unhappy because they didn't like the way things were going. They changed dramatically. You can take the worst. We took people that everybody else had said, no, thank you, that the patients had been abusive or verbally or physically or quote, supposedly. There are no non-compliant patients, but there are bad systems or bad protocols where you're not receptive and sensitive to what people need. So the lady that was in the hospital, she was a drug addict and was always in the hospital with hyperkalemia and fluid overload. And so very, very bright lady, very talented lady, smart. So anyway, what does she do? So one day she sees in the hospital, she saw a doctor's white coat and stethoscope sitting on a chair. She put the white coat on, she put the stethoscope on, and then went downstairs to get a bunch of food at the cafeteria. She's going through the cafeteria to get a whole bunch of free food because she's given the illusion that she's a physician, a doctor. But the cashier lady notices she's got yellow boots on from like hospital shoes, and then calls the police, and the police come and arrest her for impersonating a doctor. And so from that, the whole concept of, can you love somebody? Can you care about somebody? And then she went from that over a period. It took a while. It wasn't like overnight, but over time, she went from being a drug addict, got around to that drug-related environment where she couldn't get out of it. We helped her get out of it. She got a job at McDonald's and ended up being the person that was in charge of the night shift at McDonald's. Totally turned her life around. A fabulous story. The same thing with a mentally slow people. And you say, well, they're mentally slow, so they probably can't do anything. No, they can do great things if you'll adjust your training program. So we were doing a whole bunch of patients, and this one lady got upset. She said, well, what about me? She noticed that the other patients were all pulling their own needles. She said, well, why can't I pull my needles? I can do it. And then she gave them enough pressure that the staff said, okay, well, we'll figure it out. And they trained her carefully. And she became, just like all the other people, the person himself pulls their needles at the end of their treatment better than anybody, never spills a drop of blood. So the whole concept here is that if you want to dramatically improve what we're doing, we need to first awaken to the fact that we've got to get to the person and say, here, let's sit down and explain to you what's going on. And once they know what's going on, then you've got to empower them and say, we're going to give you all the power and control, coaching, training, because otherwise it's not fair to say, well, good luck, here's your stuff, good luck. But people are smart, they're bright. And then the collaboration part comes in of saying, well, if you need a pain management person, if you need a dietitian, a social worker, whatever kind of people, we can bring them in to be part of our team. But at the end of the day, the doctor, the nurse, your core team, let's say if you're in a dialysis unit, it may be the doctor, nurse, social worker, dietitian, typically. If you're in the CKD program, let's say you just have and this is how we went upstream, just like in that story about the family practice, the woman family practice doctor that ran upstream to stop people getting thrown in the river. We want to go upstream to get from disease to wellness. So you come to me and I say, gee, Tiffany, you've got some high blood pressure. You have some mild decrease of kidney function. Now, if we can control your blood pressure and keep it well controlled, you have a tiny bit of albumin in your urine, but it's small. With good control of blood pressure, we can be fine. You'll never be on dialysis. Then that goes from being a very scary, terrible story of saying, you're going to have to go on a kidney machine, to saying, we got your back. Together as a team, working together, you're going to preserve function. You're never going on dialysis. Plus, there's lots of new drugs coming out now that are very protective of both the heart and the kidney. And we can use those drugs that shut off the inflammatory process, the scarring, so that our goal, we can't do it today, but let's say 3 to 5 years from now, we won't be putting people on dialysis anymore. We'll be preserving kidney function. We'll be keeping people healthy. And so instead of saying, well, you have to go see the kidney doctor, maybe, but we're going to try to do as much as we can with the primary care physicians to work with them to give them protocols and simple, precise algorithms to say, here, you do this kind of stuff, and then be available anytime for a phone call or any way that they need support to say, you know what, with working with the primary care people, we become kind of just available the majority of the time. And only when things get really complicated do they have to see us. So our role becomes more of a cheerleader, supporter person to primary care. And with that, guess what? We then jump to the really important person, which is the patient. So taking like the podcast and saying, well, we only do this for kidney doctors. Well, what about doing the podcast for the primary care doctor?
That's right.
What about taking it the whole way? How about doing the podcast for the person, the patient?
That's
And we
right.
would like the name patient converted to person.
Mhm.
Person's the most important person in this whole scenario.
Dr. Gibney, thank you for talking to us about patient empowerment and person empowerment. And to my listeners, come back and listen to Dr. Gibney, because he's telling us how we can get involved in our health, how we can be the change that we want to see. And that's an important aspect of what has to happen next in our healthcare journey here in the United States. And you're listening to On the Record with Tiffany, and we will be right back. So come back and keep on listening.